NPTE StudyCast.
Welcome to NPTE StudyCast. Bridget, we're talking about autonomic dysreflexia. A lot of syllables there, too, and we don't want to confuse it with an earlier episode of orthostatic hypotension.
That's right.
Some similarities, but also some differences. So we'll start with, what is autonomic dysreflexia?
So it's an excessive sympathetic nervous system activity, which is triggered by afferent stimuli. So usually it can be noxious or non-noxious. It's usually a noxious stimuli below the level of injury.
Okay, so an example of that would be, that always kind of comes up in PT school, would be?
A spinal cord injury.
Right. And then maybe like a kinked catheter or something affecting the lower extremity that, normally we'd be able to move or stop, but because of the injury, we can't feel it. We don't know.
Yeah, so it can be anything from clothing and a person overheating to a UTI, a bowel impaction, which we see a lot in this population. You kind of talked about the catheter blockage or any kind of like skin irritation.
Yeah, so it's something that your body's letting you know something's wrong, and then you, as the PT or the healthcare provider, need to recognize that and know what to do next.
Exactly. And also, I think it's important to know that it's usually affecting people with spinal cord injuries at the T6 level or above.
Now,
doesn't mean that it can't happen below that, but it's typically T6 and above.
Anatomy.
All right, now what's involved anatomy? We mentioned a bunch of different anatomical structures so far, but what else could be involved?
I really think just the biggest thing is knowing kind of what level it can occur at. So again, it's going to be that noxious or non-noxious stimuli that can affect the person, and it's going to be affecting the sympathetic nervous system. So just knowing that you're typically going to see it with that T6 level of injury or above.
Differential Diagnosis.
What else could this be if you're seeing this in person?
Right. So this is where it gets a little bit tricky with orthostatic hypotension. A lot of times they kind of look the same, but the biggest thing you're going to want to do there is just take somebody's blood pressure when they're having either types of symptoms. You're going to know right away whether their blood pressure has dropped and it's orthostasis versus if it's actually staying the same or increasing. And that's where you're going to start thinking a little bit more autonomic dysreflexia. It can also be migraine because a lot of the reports from patients are just that they have a pounding headache. Essential hypertension, again, if somebody's just becoming hypertensive with a certain activity. And then sometimes it can present like anxiety or even withdrawal from some sort of drugs, or in a patient population that maybe has been abusing drugs and now they're withdrawing. So it can kind of be any of those things, or they can kind of present the same way.
Special tests.
Is there a prove it or disprove it special test situation? I mean, you mentioned blood pressure. I feel like that's a big indicator.
Yeah, so you want to, basically it's a clinical kind of diagnosis. So you want to look at the signs and symptoms. With AD, the signs are going to be a very rapid increase in BP. It's not always going to increase their BP, but if it does increase, it's going to be a pretty quick increase. They're going to have decreased heart rate. A lot of times they'll have goosebumps. They'll have diaphoresis and flushed skin, so they'll appear a little bit red above the level of their injury. The symptoms that they report is going to be that pounding headache, chills, anxiety, nausea, things like that.
Got it. Looking forward to the NPTE, the big test. How might this appear there?
I think a lot of it is going to have to do with incorporating a patient with a spinal cord injury into identifying AD and maybe what level spinal cord injury they have and knowing that related to AD and then how to manage it. Going back to what a PT would do about it is you're going to immediately sit this person up, which is the exact opposite of orthostatic hypotension. Right. So you're going to sit this person up and then you need to quickly identify what the irritant is. So again, kind of those things that we talked about, whether it's catheter or maybe they're overheating or something's irritating their skin, things like that.
Autonomic dysreflexia, blood pressure goes up, sit them up. And then going the differential diagnosis for OH, blood pressure goes down, lay them down, feet up. Got it?
Exactly. You got it.
Nailed it. All right, cool.
Perfect.
NPTE StudyCast. Brewed by the PT Pintcast.